MOS.
Good
Good
evening,
evening.
sir.
Good evening, sir. Good
Sitting
evening.
in
Good evening.
opinion only whole day.
Good evening, Atul sir. Good evening, Atul sir.
Good evening.
Hello.
अतुल
पाऊस
सर
कसा
ओपनिंग
आहे?
किती वाजेपर्यंत आहे?
नाही आमच्याकडे बाहेर पाऊस चालू आहे आज सगळं. जोरदार पाऊस चालू आहे. पहिल्यांदा किती दिवसांनी पाऊस पडलाय.
क्या बात है, very good.
Enjoy first rains, Atul.
Good.
Okay, sir. We are live, sir. We are live. We can.
Okay, okay.
Yes. Yes.
So very good evening, everyone. And we are here live with the MOS, another webinar for postgraduates. And MOS this month is doing a specialty of strabismus and pediatric ophthalmology. And this is happening with the support of MOS office bearers. And to address us, we have Dr. Santosh Agarwal sir here. Over to you, sir.
Yeah, thank you, Sumit. First of all, good evening to one and all. I welcome you all to this unique PG webinar, which has been crafted by Dr. Sumit Lahane and Dr. Vardhaman and his team, scientific committee team, Aditi, everybody. Today's cases, as already Sumit has highlighted, pediatric cataract and squint, which are very important as far as your viva or exam is concerned, practical exam is concerned. And also in our day-to-day practice, we see so many cases of pediatric cataract and squint. It is very difficult. It poses many challenges while dealing with such cases, pediatric cataract especially, because diagnosis, then examination, and also the treatment part, everything is challenging. So today we will have insight of all these cases or these diseases in depth. I am grateful to all experts, especially Dr. Nanoma Darade, Sir, Dr. Jyoti Metalia, Dr. Vaishali Une, Dr. Sushma Kulkarni as a moderator, and my MOS team. And special thanks to Dr. Sumit for running this project for the whole year. What I want to tell the PGs that learning is a process, and there are 2-3 things very important. That is, one is reading. Whatever you want to learn, first read it. You may not understand it in the first reading, but the understanding the concept is very important. Always ask why, how, whenever you read anything. Ask your teachers, your mentors, and then revise whatever you have read. Revise, practice, practice, practice. Then you will be confident. So this is the learning process. Today's PGs, I wish them all the best for presentation. And my today's quote is about success. How to be a success? How to get the success? So S stands for see your goal. So your goal should be defined. U for understand the obstacles. C for create a positive mental picture. Again, C for clear your mind of self-doubt. Whatever doubts are there, you should get it cleared. E stands for embrace the challenges. S stands for stay on track. Don't distract yourself. There are so many things around you. And lastly, S for show the world you can do it. So I can do it. That should be your confidence. So with this, I thank you for giving me this opportunity to interact with you. Over to Dr. Sumit, please.
Thank you, sir. Thank you for that nice and inspiring quote and your everlasting enthusiasm always for this PG teaching. So I would like to introduce and thanks on behalf of MOS, Vaishali Une ma'am as our mentor and MOS faculty for today. Ma'am is a professor and unit head at Aurangabad Medical College, and she is a very enthusiastic part of our MOS and all the PG teaching program. Thank you, Vaishali ma'am, for being there. And we have Dr. Jyoti Matalia ma'am. Ma'am is a national faculty for today. She is from our very own Maharashtra, and ma'am did her undergraduation from Nair, and she did her fellowship in LV Prasad Eye Institute. Presently, ma'am heads the Department of Pediatric Ophthalmology and Strabismus in Narayan Netralaya, Bangalore. Thank you, Jyoti ma'am, for being there just on a single message. And our mentor for today is Dr. Darade sir. Darade sir, as I know, is the most approachable professor available for anything, for everything. I call him, and sir is always available to help us. Thank you, Darade sir, for being there and taking so much of interest in PG education. Our moderator for today is our dear friend Dr. Sushma Kulkarni. She has done her pediatric fellowship from HV Desai Eye Hospital and presently practicing in Aurangabad, and she is also assistant professor in the Noor Hospital. And the real celebrities for today is Dr. Gayatri from DY Patil Kolhapur and Dr. Priyanka from GMC Kolhapur. They will be presenting. Both of them are exam going residents from the respective colleges. And I would hand over to Sushma for the further course of the action.
Good evening, everyone. Thank you so much, sir and Moss, for giving me this opportunity. So we'll start with the today's session. We'll start with our first case, Dr. Priyanka. Are you ready with your case?
Yes, ma'am.
You can start sharing your screen.
Good evening, everyone. Myself, Dr. Priyanka Jadhav. I will be presenting a case of pediatric cataract. First of all, I will like to thank all the MOS committee member for giving such a great opportunity to present a case on such a big platform. I would also like to thank my guide and mentor for their constant support. To start with, a 4-year-old male child was brought by his mother to the hospital with chief complaint of white color reflex in both eyes since 1 year. Child was brought by his mother with complaint of whitish reflex in both the eyes since 1 year. Mother gave history of recurrent fall of child while playing. He was unable to trace and recognize the toys also. There was no history of spectacle use, no history of trauma, no history of vomiting, diarrhea, no history of deviation of eye, no history of abnormal movement of eye. Antenatal history, all trimesters were uneventful, no history of any intake of drugs or radiation exposure, no history of fever, rash, no history of trauma. In birth history, it was uneventful, that associated with full-term normal vaginal delivery. Place of delivery was hospital. Birth weight was 2.6 kg. There is no history of NICU admission. Postnatal period was also uneventful. Developmental history, child attained all the milestones at appropriate age. Immunization is complete as per schedule. In family history, there is no history of consanguineous marriage in the family, no history of similar complaints in family. In personal history, it was normal. On general examination, vitals were stable and all other findings were normal. On systemic examination, all systemic examination findings were within normal limit. So on ocular examination, facial symmetry present, head posture normal, forehead was normal, then eyebrows at the same level. I would like to first describe right eye, then followed by left eye. So in visual acuity, in right eye, PLPR was accurate. In lids, normal. Conjunctiva was normal. Cornea, clear. Anterior chamber, normal depth with clear content. Iris, color pattern, normal. In pupil, it was single, circular, central. Size was normal. White reflex was present. Direct and consensual reflex present. In lens, complete white opacity suggestive of total cataract. Rest other findings were also normal. In left eye, visual acuity was PLPR accurate, lid normal, conjunctiva normal, cornea clear, anterior chamber normal depth with clear content, iris color pattern normal. In pupil, it was single, circular, central, size was normal, and white reflex was present, direct consensual reflex present. In lens, complete white opacity suggestive of total cataract, and rest other anterior segment findings were also normal. In fundus examination, on distant direct ophthalmoscopy at 1 arm distance, no glow was seen in both the eyes, and due to the complete total cataract, the res fundus details was not clear, or not visible. So my provisional diagnosis is both are developmental cataract. Thank you.
You can stop sharing.
Very good, Priyanka. Dayade sir, you can ask the questions.
Okay, Sushma, thank you. Priyanka, nice presentation.
Thank you.
Can you differentiate how to differentiate between congenital and development cataract? Your diagnosis
Yes.
is developmental cataract,
Yes, sir.
right? So how to
Yes.
differentiate?
Sir, congenital cataract is usually present at the time of birth or just after the birth, and it involves embryonic and fetal nucleus. In developmental cataract, it is present since infancy till adolescence, and it involves infant nucleus and adult nucleus.
Okay. What are the
Yes, sir.
most common causes of pediatric cataract?
Sir, the most common cause being idiopathic cause, then hereditary cause, autosomal dominant inheritance being most common, and in maternal factor, maternal malnutrition, torch infection, that is toxoplasma, rubella, CMV infection, and herpes infection. Then any history of drug use like corticosteroids, thalidomide, any history of radiation exposure, in fetal factor, metabolic disorder like galactosemia, hyperglycemia, hypocalcemia, and also prematurity or any history of birth trauma. Uh, these are the common causes.
Okay. Okay. Good. What is leukocoria?
Sir, leukocoria is a white reflex which can seen in congenital cataract, in retinoblastoma, retinopathy of prematurity, exudative retinopathy of Coats disease, toxocariasis. These are the common cause for
Very
leukocoria.
good. So what is the exact correct time to operate these congenital cataract cases? What time?
Sir, in congenital cataract, for unilateral cataract, we have to operate as soon as possible or up to 4 to 6 weeks of age, because unilateral cataract are more amyloidogenic. In bilateral cataract, we can operate till 6 to 8 weeks of age. Before the foveal fixation development, usually we have to operate. As 6 weeks to 6 months is the critical period.
Okay. If a patient has bilateral cataract, first
Yes, sir.
cataract it will operate. Second eye, after how many days or months it is going to be operated?
Sir,
Second eye.
after within few days to max
Yes.
to max 1 month duration should be there. Before 1 month, we have to operate the other
Should
eye
be within a days. Okay.
within
Okay.
a days.
Okay. Would you suture wound in the congenital cataract after surgery? And if yes, why? If no, why?
Sir, yes, we do suture the wound in congenital cataract
Why?
Because of suturing, the wound stability is better because child has tendency to repeatedly rub the eyes. Also, there is low scleral rigidity. So, because of that, fish mouthing can occur, which may result in improper opposition of the wound. So, post-op complication like wound leak, iris incarceration can occur. So, to avoid that, we do wound suturing. Usually
Which
multiple
material? Which material is usually?
Sir,
With
we
the
prefer
suture?
absorbable suture, that is 10-0 Vicryl.
Okay.
Yes, sir.
Good. What is visual axis opacification?
Sir, visual axis opacification is any opacity in the media in the visual axis. So, it is the most common complication after the pediatric cataract surgery because child has tendency of severe inflammatory response, and also the after cataract is more common in pediatric cataract after post pediatric cataract surgery.
Okay. Very well answered. Thank you, Priyanka. Nice
Thank you, sir.
presentation.
Thank you, sir.
Over to Sushma.
Yes. Very good, Priyanka. I would like to ask to the panelists now, ma'am, what is your preferred IOL calculation method in your practice and experience in pediatric age group?
Shall I take it, ma'am? Or you want
Yeah,
to?
yeah, you can take.
Yeah, ma'am is answering.
No, I said you can speak first,
Oh.
no problem.
Yeah. So at the outset, I'll really thank MOS and for giving us the opportunity. And very good, Priyanka. You scored a century as a opening batsman itself. You answered very well. and I'm really glad that you have the good concept of pediatric cataracts. So as you only thing is what prefer the questions you answered. So just the chronology should be you should answer what is more common and more commonly seen rather than the first. It's of no use that if you tell something like in leukoporia or any other question. So prioritize your answer properly. That much, but otherwise you answered really well. So coming back to the question asked, it is really tough calculation of IOL power, and especially so in government hospitals when we are not so well equipped with all the equipments needed for a pediatric age group. But there are many guidelines, and for usually the Hopper-Q and Holaday formula is being preferred. And earlier, I used to, though it was very gross, but then Dahan et al. Formula was very important that, okay, according to the eggshell length, the 20% up to 2 years of age, you reduce it. And for and more than 2 to 8, then we do it by 10%. We do the calculations accordingly.
Yeah.
So,
So,
ma'am, what?
yes. So I prefer the SRKT. Yeah, at the beginning, I would say, Priyanka, good presentation, and you covered the answers well. A few things I'll add after I finish answering this question. So, yes, I go for SRKT. One advantage that we have as pediatric surgeons is we tend to undercorrect. So it really doesn't matter which kind of lens you put, because invariably the eye is going to grow. Whatever you put in the eye is going to change. And there are a lot of studies done in adults, but not in children. Like people believe smaller eyeballs, so you tend to put half a Q, and then for normal action length and higher, go for SRKT. But in my practice, I prefer to do SRKT, and it's important. The calculation also varies, and each surgeon has its own, but it doesn't mean one is better than the other. One, as she said, the Dahan Drusudan, but the other one is the NIDs, where you subtract the age with -7, and then you get the exact power, and that you can do. But it's important to see what is the age, how much of post-op refraction is coming, what is the IOL calculated during on table, because the amount you undercorrect, that much lens should be there. Post-op, you should not have a very high refraction. Like if the child is already amblyogenic and you're trying to undercorrect him to more than 10-15%, you're going to give him an post-op hyperopia of +3, +4, and an add to it. So that's going to be higher. So each case is actually individualized. Also check if it's unilateral, it'll be different, because then you have to match with the refraction of the other eye. So many a times, but so the plus point that we have is, yes, so we can undercorrect, we can plan, and we don't have to aim for like perfect emetropia like you have it in the adult case. One thing which I wanted to ask you, Priyanka, why would you say that this particular case you presented is not congenital? Because this has already come with a mature cataract.
As the presentation, because till the as child is 4-year-old, if it is present since the birth, that his mother must have bring the child earlier, so it must have started at later stage of life. So
Yeah, that's a
there are
good point.
most probability.
Anything additional in your findings?
Ma'am, it is not associated with any abnormal movements or squinting.
Yes,
So mostly
right.
it can be the developmental.
Yes, so you have to look for these things also. That's very
Yes,
important.
ma'am.
Absence of nystagmus or any abnormal movement tells you that fixation is already developed.
Already developed.
And then the patient develops. So these are signs which tell you that even if you delay by a few weeks, which is unavoidable, but you won't lose too much. So it's important to look at that. Yes, right.
Yes, and the bookish criteria is okay. It's okay for answers in Viva that you wait for so many hours. Ideally, whenever a child comes with cataract and you know that the patient is not having vision now, it has come down to PL and PR. So don't wait for the ideal thing, even unilateral such thing, bilateral. You need to operate because you have to avoid the amblyopia.
Yes, ma'am.
Ma'am, when is the earliest age at which we can implant the IOL?
The RPC guideline, I go by those guidelines that if the axial length is, if it is 17 mm, and also the white to white diameter of the cornea. So that is 9 to 10 millimeters. So that would be the criteria for implanting IOL. again, there are so many criteria because we have to wait for the pros and cons. Implanting an IOL has its own this, and not implanting also has its own thing, because managing a pediatric cataract is totally a different ball game. So ideally, I go by these criteria if whenever a child comes for implant, when it comes to implanting an IOL.
Yeah, so I would advise that implanting an IOL ideally best over 2 years, but now it is under one, over 1 year. So anything over 1 year, I would implant, but as rightly Dr. Vaishali said, that the actual length should be definitely more than 17. I prefer to have it more than 19. The corneal diameter should be more than 10 millimeters. And why that is? Because if you look at all the lengths, the IOL overall diameter is 13. So imagine if you put that lens in a child who's less than 10, you're going to cause a disaster. So that's what is important. It's not about putting the lens. Important is you have to give a refraction post-op. So you need to explain to the patient that, yes, I'm removing the cataract, but that's only 10% of my job. After that, whatever I give, whether it is glasses, contact lenses, that is going to improve the vision. So that you have to reinforce. So putting a lens or replacing it with a contact lens or glass is not important. Giving it right, yes. But if you find that the patient has got poor compliance, he's more than 1 year, definitely you can implant the lens earlier. But remember, as she rightly said, post-op complications are very high. Putting the lens in a small eye, which has got low rigidity, there's more chance of inflammation. You can have more problems. So it's better to put it, the later the better. So I would keep 1 year as a cutoff.
Ma'am, what do you do in case of microcornea, elderly child with both eyes microcornea? So do you ever use customized IOL or keeping it off-peaking, which is preferred?
Yes, so it all depends on the size of your IOL, size of the cornea. There are certain, Orolab has its own lens, which is called as Oroped, that is Oroped lens, which has a 10.25 diameter. So you have whatever is your corneal diameter, you add 1 to it, and that will be your IOL length. I have put a couple of customized IOLs. In children, I have a paper on microcornea and management with customized IOL, where I have customized the lenses. Initially, the eye care company used to make customization. So you measure your corneal diameter, add +1 to it. But these are non-foldable lenses. These are rigid lenses. So you need to put it like a PMMA lens. So you need to make a scleral tunnel and put that. But remember, initially, now we have a lot of studies that talk about hydrophobic lenses as one of the best hydrophobic acrylic. But in the olden times, it was PMMA. And PMMA is one of the very good materials which is meant for IOL. Yes, the only disadvantage is that you cannot fold the lens. But it is extremely good and causes least inflammation in the eye. So yes, wherever needed, you can definitely put in. But as I said, calculate your horizontal corneal diameter, add +1 to it, and that should be your customized IOL.
Ma'am, how many times you have encountered the secondary glaucoma in pediatric cataract cases, and how do you tackle that?
For me, it is
glaucoma I've seen if you operated very early.
Yes.
No, you go on.
Ma'am, please go ahead.
So in children where you have operated less than 6 weeks, have more chance of more chance of getting secondary glaucoma. So the later you do, the better it is. Also in children where there's microcornea, the chances are more. When you leave the child aphakic, the chances are more. Yes, so the ideal would be if you operate more than 2 months, when the child is over 2 months of age, and it's not a microcornea as a first sitting, the chances of developing secondary glaucoma are less. Yes, when you have patients who land up with glaucoma, usually you start them on medical treatment, but it is not the treatment of choice. You invariably have to go in for surgery. So we have the advantage of being in Narayanitra, so we have a glaucoma department, but usually they start with trabs, try to see if you control it, and if not, a second trab, and then eventually consider doing a valve.
Me, it is like same madam said, that if you leave a patient aphakic, baby aphakic, so you have to be on the watch out for the IOPs. And the dilemma is more in GMCs, like the patient coming and getting operated for cataract and coming for the follow-up. So that is important itself, but then most of the patients get the eyes operated and don't come for follow-up. So I'm really like the incidents in my cases are less because we have less follow-up. But yes, of course, 10 to 25% is it is there in the paper. So risk of glaucoma is definitely there, and we must be on the watch out for glaucoma.
Have to
So
keep a
which brings us to
lifelong.
an important aspect that you need to follow up these patients very regularly. Every 6 months, you have to check. So in children, yes, IOP can be done, but sometimes if they're crying and all, it's difficult. So regular EUAs also check the horizontal corner diameter and enlarge axial length. So you aspects when you're checking for the axial length and yes, IOP. So these to be checked so that you don't miss them, because the cupping and all will also increase. So in children, it's the axial length that tends to grow, and you may sometimes miss the actual cupping that is happening.
Jyoti ma'am,
I think one more question Dr. Sumit was mentioning is about the size of the optic when you customize the IOL. So usually it is about 5 to 5.5. So the overall, so that they automatically customize depending on what lens, what's the overall diameter. So up till now, the smallest lens that I have put is about, the customization was about 11.5, and that I have had a 5.5 size. But the 10.25, which is a standard customized IOL already available in the market, and that's of the fixed size, that's about 5 millimeters is the optic.
So one case, my earliest was I did of 6 weeks baby, CRS baby, and I kept it aphakic. And luckily, after 3 years, he came for follow-up, and his pressures were not raised. So you can sometimes be lucky, but that is not always so. You have to be on the watch out for the visual axis opacification, for the glaucoma, and again, secondary cataracts. That is also very important.
Ma'am, how many times you have encountered primary posterior capsular defect or dehiscence? Like many times in PFV and in other types of cataract also we can see that, and how to manage that.
So I see about 20 to 25% of my patients would have it. So you can anticipate prior, depending on what it is. If it's a totally mature cataract, yes, it is difficult. Now, any child under 8 years is somewhere, I would anyway do a primary posterior capsulectomy. So that doesn't matter if it is existing. But yes, if you feel that it's an older child, you want to avoid it. So a few things you have to be sure before when you do is try to keep the chamber height low when you're doing, basically for irrigation aspiration. Try to, while you're exchanging instruments, try to put in visco from the side port so that you avoid fluctuations of your anterior chamber. Then when you're aspirating, also aspirate more from the periphery, and the last part you leave is the center, so that just in case there's a sudden giveaway or something, it can be avoided. Also, when you're doing hydrodissection, don't do a complete hydrodissection, do incomplete multiple quadrants, because sometimes you need to do it since the cortical matter is very sticky and you're not able to eat it up. So it's important that you do. That's here. And then eventually, when you are finally leaving, the center is the last thing that you eat. You can also do a hydro delineation, but if you have any doubts that the fluid wave may go behind and the PC may give way, then it's avoidable. However, you should always remember that in children, the vitreous right below your posterior capsule is formed. So unlike adults, where if you do a hydrodissection, it will just go and rupture, that would not happen in children. So you really need not worry too much. Yes, nevertheless, you have to be cautious and careful when you're doing this, because these kind of tips for PPC will apply for any case, not necessarily pediatric.
Do you prefer to do optic capture in budget
So for me,
space?
I would do optic capture only if I want to stabilize the lens, or if I've already done a PPC and it's very large, then I want to do an optic capture behind the IOL. So basically for stabilization, if there's a traumatic cataract where I want the IOL to be stabilized is when I go. I don't primarily use it to prevent a PCO. But for me, when I do a PPC, I always ensure that I do an anterior vitrectomy. That's my thing, to prevent the posterior capsular opacification. Also, remember, it's very important when you do an anterior vitrectomy, you should have high cut rate, which could be anywhere from 800 to 1000 to 1500 to 2000. That's your cut rate. But the vacuum that you keep should be low, because we are trying to eat only the vitreous below your capsule, the posterior capsule. We are not trying to do a core vitrectomy. So my parameters for vacuum is always between 80 to 100. I just want to eat the rim, which is the amount of vitreous just below the posterior capsule. So many a times people keep 150, 200. In that case, you're taking too much vitreous out, and you can cause collapse and hypotony. Sometimes closure and putting the lens can become difficult.
Vaishali ma'am, do you want to add anything?
No, same like optic. If it is inadvertently, it is we find. So then you have to do the optic capture. So stabilization of the IOL is needed. That is true.
Thank you. That was very informative discussion. Now we will proceed with the second case. Dr. Gayatri, are you
Yes.
ready with your case?
The lens has to be hydrophobic and square edge. That
Yeah,
one
that-
point. Yeah.
I think Sumit has asked some questions. I think, can you answer? Have you answered those questions? At what age it is compulsory to do antravitrectomy? And what second question was?
What is the endpoint of antravitrectomy in pediatric cataracts?
Yeah, so age, I would say 8 years, up to 8 years, you should be doing an anterior vitrectomy along with your PPC. And definitely later, if the child is mentally challenged or any other issues where you know the child will not allow a yak cap to be done. The endpoint of anterior vitrectomy is once you have ensured that the vitreous is completely cleared, there is no vitreous strands coming into the anterior chamber or outside the wound, and the vitreous is way below. And the way to detect is, there are two things. You should see the posterior capsule, posterior of the PPC and the anterior capsule both should be freely moving. There should be no edges or tags there. That's one. Secondly, I also advise for early budding pediatric ophthalmologists to use the endolight. Endolight is the same light which our retina colleagues use. All you have to do is hold it obliquely over the cornea, and this the tangential light that comes can actually help us visualize the vitreous strands. And all you have to do is keep it outside. You don't have to put it inside, but certain things can easily be missed out. People also put triamcinolone inside to leave out, but sometimes it can go in the posterior chamber, and we don't want it to cause any glaucoma. And simple endolight can also work. But you have to ensure that there is no vitreous in the anterior chamber once you finish doing your surgery, because we don't want those tags or anything coming into the wound eventually.
Ma'am,
For
do
me,
you
it is,
prefer-
yeah.
Yes, ma'am. Vaishali, ma'am, go ahead.
Yeah, for me, it is like total when I suture and I do PPC in all cases, because again, the follow-up may be an issue, and we never know when the patient will come back again. So even if it is more than 8 years also, PPC is done. And for full air in the anterior chamber and the circular pupil and no strands, because I also suture in all, even up more than 8 years. So during suturing also, if there's no vitreous strands also, that I make sure that the whole anterior chamber is, the air bubble is tight and airtight chamber is maintained.
Ma'am, just one more question. Do you prefer giving intracameral DEXA? Nowadays, there were certain studies about same where you expect a lot of inflammation post pediatric cataract surgery, where you expect inflammation, especially the smaller pupils which you don't dilate and you have to use hooks or something in those cases.
I don't have any experience. Ma'am would guide us.
I don't have experience either. One thing which I am very particular, I mean, it's true that in my cases, extremely rarely I find any inflammation post-op, but that could be because touching the iris as minimally as possible is very important. Immediately post-operative, I give subconjunctival DEXA and antibiotic immediately before I close. And I also put an ointment of this antibiotic and steroid, so that when the patient I open this patch the next day, I find the eye pretty quiet. But yes, a lot of people give, so I would not say that it's not a right practice, but in my experience, I prefer to do this rather than giving intracameral.
In traumatic cataracts, when involved in pediatric cases, I give a depot of triamcinolone.
Gayatri, go ahead.
Yes. Good evening, everyone. Before beginning my presentation, I would like to thank all the MOS committee members I would also like to thank my teachers and mentors for guiding us throughout. Coming to my presentation, a 14 years old female child came to ophthalmopedy with complaints of outward deviation of right eye. Child was 6 months old when her parents first noticed the outward deviation of right eye, which was insidious in onset, gradual, and progressive. It was not associated with history of fever or seizures, no history of trauma, no history of spectacle use or patching of the eye previously. Family history, there was no history of consanguineous marriage of parents. no history of thick spectacle use, no history of squint or squint surgery in her family. Birth history, she was born out of a full-term normal vaginal delivery with a birth weight of 2.5 kgs. There was no history of NICU admission and uneventful postnatal period. Her milestones were achieved at appropriate age and child was immunized till date as per the schedule. On general examination, vitals were within normal limit. Coming to ocular examination, there was facial symmetry without any abnormal head posture. Her forehead and palpebral fissure were normal. Her visual acuity was tested on Snellen's chart. In right eye, her vision was 624, improving to 618 parts, whereas in left eye, it was 618 parts, improving to 69, with the refraction of minus 0.75 spherical in both eyes. Her near eye vision was N6. She also underwent cycloplegic refraction using cyclopentolate. Coming to sensory examination, on Worthford dot test for distance and near, it reveals right eye separation. She also had loss of stereopsis when checked on Titmus fly test. Coming to motor evaluation, her extraocular muscle movements, that is the versions and ductions, were full and free in all gazes. In primary gaze, she had right eye exotropia. No oblique overaction or underaction was noted in any gaze. On motor examination, we asked the child to fixate on the distant target. And in her Hirschberg test, the corneal light reflex was seen between the pupillary margin and the limbus, which was approximately 30 degrees. We performed the cover-uncover, direct cover, and alternate cover test, as shown in the video, which revealed the presence of both eyes alternating exotropia with left eye dominance. We performed prism bar cover test in right eye. Prisms of increasing power were kept in front of the eye until it stops deviating. It showed deviation of 35 prism diopters for distance in all gazes with basing prism. No pattern was observed. Similarly, when prism bar cover test was performed for near using accommodative target, it showed 35 prism diopters using base in prism. Her anterior and posterior segment examination was within normal limits. My provisional diagnosis is 14 years old female with alternating basic exotropia with left eye dominance with right separation and absent stereopsis and right eye strabismic amblyopia. Thank you.
Very nice, Gayatri. Daradi sir, you can proceed with the questions.
Gayatri, good presentation. Can you define exotropia? What is exotropia?
Exotropia is the outward deviation of eye. It is a manifest squint.
Okay. Can you differentiate between phoria and tropia? How will you differentiate between phoria and tropia?
Gayatri, can you stop sharing the screen?
Yes. So tropia is manifest squint. It is evident on gross examination. And to differentiate between tropia and phoria, we can perform a cover-uncover test. When one of the eyes is covered, it breaks the fusion. If there is any phoria, the eye behind the cover deviates. So on removing the cover, if the eye remains deviated, it confirms the presence of phoria.
Correct. What are the types of exotropia?
Exotropia are of two types. It can be comitant and incomitant. In comitant, we have in primary we have infantile exotropia and intermittent exotropia. In secondary concomitant, we have sensory exotropia and consecutive exotropia. In incomitant exotropia, we have paralytic, restrictive, horizontal, dissociated horizontal deviations or any musculoskeletal malformations if present.
Okay. What is consecutive exotropia?
In consecutive exotropia, if there was any overcorrection for
Exotropia. Yes. Overcorrection of esotropia leads to consecutive exotropia. How will you diagnose pattern exotropia?
For pattern exotropia, we give the child a fixation and we check the deviation from upward to downward gaze of 25 degrees. If there is divergence of more than 15 prism diopters from up to downward gaze, it is called as A pattern. If there is convergence of more than 15 prism diopters from up to downward gaze, it is V pattern. If there is divergence in from up to downward gaze in upward and downward direction, it is of X pattern.
Yes, correct. What is patch test? And why it is done?
Patch test is used to differentiate between true divergence excess and pseudo divergence excess. When we patch one of the eye, it breaks the tonic fusional convergence. So what happens in pseudo divergence excess is initially the deviation for distance and near is more than 15 prism diopters. But when we patch one of the eye, without exposing the other eye, when we perform the test again after 1 hour, we see deviation for distance as compared to near is less than 15 prism diopters.
Correct. Very nicely answered questions. Thank you, Gayatri. Thank you. Over to Sushma. Over to Sushma. Yes.
Very good, Gayatri. I would like to ask to the panelists now. Ma'am, how do you manage A and B patterns? How do you plan for these surgeries?
So when you are suspecting an A or a V pattern, you have to rule out if there's any oblique overaction. That is very important. So when you're looking at a V pattern, we are looking at an inferior oblique overaction where your deviation will be more. So for a V pattern, we expect a hypertropia in the opposite gaze. So that is important. So if you will get a right hypertropia in the left gaze and the left hypertropia in the right gaze, that is for the PGs to understand. You need to do the cover test in that gaze to pick up the hypertropia. So if you have an inferior oblique overaction, which is related to a V pattern, then over and above whatever you're going to operate for the exotropia, you need to do a recession of your obliques. So it will be an inferior oblique recession to tackle the V pattern in a patient who already has an exotropia, and you may plan the exotropia whatever way you want, a recess, resect, or a bilateral LR recessions. That's your call, depending on what is the cause for the exotropia. Now, if you're looking at an A pattern, then we are looking at basically a superior oblique overaction, and in that case, we need to recess the superior oblique either by doing in recession, I mean a 450-nectomy, where you cut only the posterior fibers which have a tendency for the eye to go down. So in those cases, you get a hypertropia in the same gaze. That's the way to differentiate the A and the V pattern. And as she also said, there's an X pattern. So X pattern usually cannot be a superior and inferior oblique both overacting in the same eye. That's unlikely. X pattern develops because your lateral rectus is so tight that when you look laterally, the eye slips up or down. So the X pattern is classically related to a tight lateral rectus. So in those cases, recession of treatment of exotropia by just operating the horizontal muscles is sufficient to tackle the X pattern. But if you don't have any of the oblique overaction, then we just have to displace your horizontal recti, which we call as a male. That is a mnemonic. So medial rectus has to be shifted to the apex. That is the pattern. If you have an A pattern, then it goes up. V pattern, it is shifted down. And the lateral rectus to the apical end. So that's how you call the male, M-A-L-E.
In case if we have to operate only one eye and there are no oblique overactions, so do you do it in even in unilateral cases, upshift yes, and yes. Downshift?
In that case, I would do upshift of that particular muscle and the downshift of the others. You can do that.
Vaishali, ma'am?
Yes, I was about to tell about the male. So it is very important for the residents to remember this. So if it is again the prism diopter 10 and 15, if it is more than that, and like ma'am has said that in the examination, if you feel that the obliques are overacting, so tackle the obliques. Otherwise, if it is less than 15 prism diopter, so you can just shifting of the horizontal recti will work very fine. And in many cases, they show excellent results. You don't have to tackle the obliques.
The other thing, besides looking for the oblique overaction in the gazes, you also have to look at the torsion on fundus. So you'll see an extorsion for patients who have an inferior oblique overaction and an incyclotorsion for those who have superior oblique. So you need to check that and confirm it by doing a cover test in the gazes. Once you've confirmed the obliques are overacting, only then you can touch. Though inferior oblique is a muscle where you operate, you recess, does not cause much harm because they don't really work in a primary, they don't influence your primary position. But superior oblique touching that may cause disaster because superior oblique works in your down gaze, and we don't want the child or the adult to get disturbed in down gaze. So unless you are able to prove that there's an oblique overaction, you should not unnecessarily operate on that.
Ma'am, what are your criteria to operate upon intermittent divergent squint? Like at what stage, at what you prefer to operate?
So first and foremost, we should ask, especially in children, it's more important to find out how much is the deviation. So yes, in your OPD, you will see how much it is there, how many times the child is really breaking. And there are a lot of criteria which are, there's a Newcastle's criteria and classification about deciding how to do, where you have the office control, the home control, that's one thing. What importantly you have to see is, if possible, you have to do your stereopsis. And if a stereopsis is definitely affected for near, you have to go in and operate. The other thing is, which is important, is you have to ask the parents how often they find the child squinting. If it's more than 50% of the waking hours at home, you can again look at the criteria. But remember one thing, operating on any intermittent divergent squint does not give you 100% results. The success rate is only 70%. So even if you operate, there's a possibility that the squint will come back. And that is what you have to keep telling the parents, because it's not something that you do and you're going to be fine. So unless you feel the squinting is really more, it's more than 50%, your stereopsis is significantly affected, you can easily wait. And in that time, you can sometimes even give alternate eye patching. You can give over minus glasses, ensuring that the parents are not myopic. Otherwise, the child will eat up that minus power and get it. So in doubt, do not give it. You can give alternate patching, call them more often. Also, when you plan surgery, it's important that you take 2 separate readings about a month apart. You are sure about your measurements and then only plan to go in for the surgery. I tend to do a little 5% overcorrection of my, when I plan intermittent exotropia, means if I am getting, my endpoint is not orthotropia, my endpoint is flicked esotropia when I'm doing it, so that I want the child to be a small esotropic, so that post-operatively eyes are going to drift out and then the eye will be straight. But remember, don't do overcorrection. We don't want a small ET, nothing more than 10 to 15 prism diopters. Otherwise, the child will land up with a microtropia, and that will be more amblyogenic than your intermittent XT. So it is important, individualize your case, call patients more often, take multiple readings, and only when you're sure and the squinting is more often during the whole day, then only plan the surgery.
Is the Kellam's criteria and the Newcastle's, so that tells us. And like ma'am has said, that the most important is the stereoscopic. If that is going down, so that is clear-cut indication. So many papers have been published from RPC as well, that when you find, even though the waking hours, it's definitely more than 50% of the waking hours the child is squinting. And even the office, the clinic hour examination, when we file, just make them sit and just keep on observing. So that will give the criteria, whether you need to, or just like ma'am said, follow up after 1 month, see again if you're sure you want to operate. And of course, minimal overcorrection is preferred.
Any tips to avoid over or under correction surgery?
Again, age group, if the fixation and if less than 5 years, so you can get away with the overcorrection. But, and again, we have been taught that for exo, go for overcorrection, for ESO, undercorrection. So planning the surgery is important. And again, if the child is less than 5 years, the eye is small, how much, because each millimeter counts. So you have to be very careful with the calipers, like exactly how far you are placing it from the limbus and all. So your calculations, your planning of the surgery, the intraoperative suturing techniques, and that is all, it like 1 millimeter, 0.5 millimeter also, like especially if a child is less than 5 years and we are doing the infantile ESO things. So those things we have to be very careful. And in adult or children more than 5 years, then okay, you can get away with it, with the overcorrection.
And also take multiple readings when there's no harm. We don't have to rush for surgery. We can take it, call once, twice. If you feel more often, call them more often. There's no problem. Then only plan when you are sure of your measurements. Also, suppose a patient is already an intermittent XT, you operated, again starts developing XT, you can give him over minus glasses in the interim period. If any esotropia develops again residual, you can try to give him plus glasses. So you can try doing it immediately in the post-op to see if it can help. You can give alternate eye patching. And if you feel the squint is too much, if you've done a significant overcorrection, you may need to go back and undercorrect that. So those kind of things are there. Also, there are certain guidelines in multiple textbooks, like you have a Rosenbaum guidelines. Choose them initially, use those criteria, do multiple surgeries, then you will be able to set your own guidelines, and then you will be able to know exactly whether you should follow them or you should undercorrect or overcorrect. So it's like as and when you do more and more, you will be able to make your own guidelines yourself.
Thank you, ma'am. Now, should we proceed with the case scenarios?
Sure. Yeah, sure.
I forgot to congratulate Gayatri. Gayatri, you did really well. Nice presentation.
Thank you, ma'am.
So I will be presenting two small case scenarios. So this is my first case of a 6-year-old girl with the right eye vision is counting finger 1 meter and left eye 6 with a very minimal refractive error in right eye and no improvement. The Hirschberg is showing right eye esotropia. Modified Krimsky is around 50 prism diopters of esotropia. Right eye is having eccentric fixation. Extraocular movements are full and free. So you can see the right eye is in esotropia. So very poor or rather eccentric fixation in right eye. So I had advised her conventional left eye patching for 6 to 8 hours per day. She did it for 6 months. She was very compliant with it as told by the parents. So the vision improvement after 6 months was from 1 meter to 3 meter, but there was no improvement in eccentric fixation. Rather, it has worsened. You can see I'm showing her fingers right from the center, and she is fixing this much rather peripheral fixation. So now what to do? So I'm trying with the inverse occlusion after reading with few articles. I have started her on full-time inverse occlusion of right eye to break the eccentric fixation into the wandering fixation. And then I'm planning to start with the conventional left eye patching again. So after 1 month of inverse occlusion, little bit of wandering has started, I feel it. So what are your opinions regarding this case?
This is actually a very difficult case, not very easy. And she's already come at 6 years of age. As you rightly said, we can close the right eye completely. And then after that, we need to give some stimulation for the fovea to regenerate, in the sense to start seeing. So sometimes people have tried giving red filter. You can also have these Heidinger brushes exercises that can be given on synaptophore. So all this is theoretical. I really have not seen. I have tried doing it, but I have not got much, any improvement in children like this. They come in with so whatever you're doing right now, since the fixation is not developed in the right eye, it's unlikely it's going to develop. So these are the options that can be tried by giving the Heidinger brushes. But again, I was looking for multiple options. They're not so easily available, where you stimulate your fovea on the synaptophore and try to give exercises. But red filter can be tried to see if you can stimulate the fovea.
How do you prescribe red filters, ma'am?
No, I said theoretically. I'm not really sure. I've not been able to get much experience with these. I've not seen any improvement also happening more with them. You need to completely close the right eye like for 2 months and then try giving it. So anyway, we get those red filter light off films. I think we'll be able to order, but I don't know whether it really helps. So they say that you can try doing it. We have tried to get those synaptophore we have to see if we have those Heidinger brushes exercises that can be given on that. Where the child comes in and you try to stimulate. It basically works on your fovea, the macula, and those brushes work in a way that they start stimulating your fovea again.
And what about, I would have thought of operating her, like considering her infantile like cross fixation and a large angle. So what if we try and give her binocular, first correct the esotropia and then proceed?
For me, if you close the left eye, I don't see absolute fixation, not even a little bit of fixation in the eye. Whatever we are seeing, we're not even sure about the eccentric. So even if you correct them for cosmetically, if the eye is going to look okay, the child is not going to use the fovea either way. She's only going to use that point. And we never know, this will go into an XT. So I would definitely want to see if I can get anything improvement in the vision before I would want to go in. For me, doing squint surgery would be entirely cosmetic in her case. Then it would help in for any functional or any from that point of benefit.
The newer methods of treating amyloid.
I don't think so. We have to break her eccentric fixation has to be broken. Unless we do that, anything else is not going to work, because whatever we are giving her now, if we give a binocular also, we are stimulating that eccentric fixation point, which is going to make it stronger. And we don't want that to work. We want the fovea to come back. So what you said, right, closing the good eye and trying to see if we can get the fovea back to its strength is what will be the first line. Otherwise, whatever we do binocularly, we are just trying to stimulate the right eye and the eccentric fixation point, not the actual fovea. So it would never be able to attain the 100%, and she'll always have this. So we need to break that. But these are difficult, not something which you can get, and you would get one or two of these cases, which are not easy to, really not know what exactly to do in these situations, because we don't have clear-cut, exercises and all which are available. Yeah, let's do this, will come. And again, to be able to close the good eye, the right eye completely, to send her to school like that is not easy. It's like a big taboo. And even if you do, parents will not be able to do that. So there are a lot of practical issues also that come into play.
Madam, what is the reason for eccentric fixation in this case?
In this case, entirely because of the esotropia. The child has developed esotropia in childhood, because of which this eye has started seeing. So a non-foveal point has become the center as a fovea it started working in, and therefore you'll end up with an eccentric fixation.
Okay, thank you, ma'am. So I will proceed with the second case. So this is just a simple case of large exotropia. Both eyes visual acuity 612 improving to 6.6. Harshbagh is showing left exotropia, and the prism cover test for primary upgaze and downgaze is showing 70 prism diopters for near, 65 prism diopters. Extraocular movements are full and free. So it is alternating exotropia with right eye dominance. So in this such cases of large exotropia in adult, how do you plan the surgery? Whether you plan for the 2 muscles or 3 muscles or stage surgery, ma'am? I had planned for the stage surgery. I did 2 muscles in left eye, and it was good. No need of second surgery. So, but many times we encountered 80-85 prism diopters of exotropia. So what to do in these cases?
Just want to know how much of recess resect you did?
Ma'am, 8.5, 6.5 LR recession, and maximum which I could do.
Because for 70 PD, you are able to attain with this much. I'm impressed, because for me,
for distance, there is little bit of 10 to 12 prism diopters of exotropia is remaining for distance, but he is fusing it nicely now.
Okay, so
I was also thinking of doing 3 muscles when you showed the pre-op pictures.
True. So, I mean, my protocol is anything up to 45 PD, I would do 2 muscles. 50, I could do, means in that 2 muscles, and I could do a bilateral LR recession. I'm talking for exotropia. Okay, up to 45. If it's 50, bilateral LR recessions will not work. If it's 50, I will do one eye recess resect to get a 50 PD. 55 and above will definitely need 3 muscle surgery. Reason for doing 3 muscle surgery is you do equal lateral rectus, so that the incompetence in the gazes is avoided. People can also do one eye where they do basically hang back, or is that muscle transplantation can be done. But I'm not sure about the incompetence coming in. To get in squint, I always believe doing a simultaneous and symmetrical surgery prevents more issues, especially looking in side gaze. So if it is more than 55 to about 80, obviously I will do 3 muscles. And anything over 85 and above, I would require 4 muscles. But what happens is, in anything, I have lately operated 2 patients in which it was 100 PD. So 100 means I did not even have the prisms. One was 50, one was 45 still. But these patients post-operatively also landed up. It never got corrected. The reason being 100 is what I could only measure. And still the eyes were laterally being stopped by a canthi. So we are not sure whether the squint is more than that. The only advantage there is because I operated 4 muscles, I have a possibility of going back and doing a replication or a re-resection of your MR, which is there in our hand. So even if they recur, it's possibly going back and doing the medial rectus resections. I'm talking for XT. So that is what I would do. So anything over 85, I think I would do 4 muscles. 55 to 80 is where 3 muscles will work.
How is your, have you done muscle transplantation as you said? So
yes,
how does
I
it
have
work?
done muscle transplantation. And for squint surgeons who are budding, it's like a thrill to do the muscle transplantation, frankly speaking, where you're taking a segment. But eventually what you have to realize is whatever resected segment you've removed, and then you've attached it to your recession and increase the recession, eventually that muscle is not going to develop. So rather, there's a very good paper by Amit Pujari who has written, rather than doing the transplantation, you do the maximum amount of recess detect and put a hand back. That will work the same way. But yes, as surgeons, as pediatric, we would like to do it anyway, removing the segment. Why not add it there and do it? So it does well, it does do well, but it's a lot of tedious, a lot of things to do. So the same thing can be applied by doing a hangback with a large recessed segment.
And one thing I noticed, his vision is good, luckily, even though, like, had this been a sensory XT, then he would have come back again. So we need to do a larger amount of surgery. So it's good that you got with just one single 2 muscles also, you got great results. So it's appreciable. I just hope he doesn't revert.
Yes. But it's a year now and he's happy he did not come back.
Good.
I know finally our goal is to make the patient happy, and if he's not having diplopia and his eyes are straight enough, that's good. I mean, anywhere between 10 prism diopters here and there should be easily allowed, and patient has no symptoms or any discomfort, that should be good.
The mention of diplopia, I just remembered that again another criteria for IXT when to operate intermittent exotropia. So in the sunlight, most of the parents will say that whenever the baby is out, they will close one eye. So that diplopia phobia, as coined by Sir, is like, so look out for that also, that if there is, the child squints more in sunlight. So that is another criteria for going for surgery.
Have you encountered post surgery esotropia giving very troublesome diplopia? Even 8 to 10 diopters of esotropia patient, young adults, are coming with very troublesome diplopia. So how do you manage those cases? Giving the prisms or...
Yeah, so it depends on how immediate it is. Yes, we tend to keep about 8 to 10 PD should not be a problem. Yes, sometimes we have anxious patients and they would be worried. So give some time to them. Tell them that you can give some, don't, and we have to explain to them, don't run after double vision. You will see it, but give some time for the eye to settle out. You can also introduce patching of the other eye so that it resolves, and 8 to 10 is not too much. See if the patient also has some amount of hyperopia, which you can give to him as glasses, and see if you can relax that. And if the patient is still very uncomfortable, eventually you can definitely incorporate the prisms, which you can slowly taper off. But reassuring is very important because we need that 8 PD of esotropia in the patient post-operatively so that the eyes straighten out. Because in the long run, these patients will again develop an XT. So just keep on reassuring. If you are confident in convincing and talking to the patient, then the patient is relaxed. So that's important. We should, as doctors, not panic. Oh, we got it. It should be like, this is what we expect. Relax, it'll be fine. Give some time to the patient, he will be okay. So you keep on reassuring from your side.
And pre-op consent also, that time also, so patient is not very hesitant when he feels he has diplopia post-op. So he is aware of it. So that is also a part of counseling, what we do pre-operatively.
So one thing you can actually tell is, see, when your eyes were drifting out, you never saw double vision. Now the brain has started accepting the eye, so it is taking time for it. Now the brain is going to work them, get them together, and now eventually you'll get a single vision. So give some time, it should settle down. But there is a concept of ARC which can come, especially the paradoxical diplopia, which can also be there, which in those cases can be really troublesome. So see that, then you may need to introduce prisms or something if the patient is really getting bothered by that.
2 to 3 basic questions can I ask, Sumit?
Yes,
yeah,
sir.
you are muted.
Yes.
You are muted.
Yes, sir.
Yeah.
Yes, sir.
Role of eye exercises before and after surgery. What is the role of eye exercises? Is there any significance?
conversion in exotropia when there is, and again, intermittent exotropia is there, and we feel that there is still no need, the patient can wait for surgery. So definitely we can go for the pencil push-ups and the convergence exercises.
Even post-operatively, if your XT has recurred again and you want to give something, so you can give exercises, there's no harm. Basically to allow more conversions in our patients post-op.
In pediatric esotropia or exotropia, when we should operate the patient?
So ideally, if you in exotropia, if it's more than 50% of the waking hours, listen and intermittent, yes, you should. If it's a constant XT, the minute you come to know the patient has given you 2 correct readings, which you're sure about, a month apart, you can go in for surgery because you're the operating surgeon. Your aim in case of esotropia would be aiming orthotropia or a flick esotropia. Do not overcorrect too much. Subtle overcorrection is okay because eventually the patient will be okay. Overcorrection is, I mean, 2 to 3 diopters. With an exotropia, I would aim for a flick esotropia post-operatively, about 5 to 8, because I want the eyes to be in and eventually straighten out, because exotropias are subsequently go back into exotropia. So recurrent exotropia is very common. So to avoid that, we tend to overcorrect them. But if the squint is constant and you have got 2 readings 1 month apart, which are perfectly same, you can go ahead with the surgery.
And for esotropia?
Sorry?
For esotropia.
Yeah, esotropia, same. Aim for orthotropia. If any constant squint, definitely give glasses. In case of esotropia, if it's intermittent, do a very good cycloplegic refraction. Check if there's any glass power. Make the patient wear glasses. 6 weeks later, check the glasses. If the squint is corrected, nothing to worry. If it is still residual, take the measurements and operate for the residual squint. In esotropia, something else that you have to take into account is the squint may be corrected for far, but for near, he may still have an esotropia. Then we are looking at something called high AC by ratio, for which we have to introduce bifocals. And these bifocals have to be gradually tapered over time.
Like broadly, I would like to tell all the residents that whenever you have a squint case, so do cycloplegic refraction in all cases, see the vision, and if the amblyopia is there, manage the amblyopia first and then post for surgery. So broadly, if they have to know how to manage a case of squint.
Madam, I know that there is no definite relation between how much recession or resection you do and how much correction would be there. It is different in every case. But as per your experience, how can you formulate that? In recession and resection, how much millimeter will give you how much result?
I think for exam going, we can say that usually what I tend to follow, there are certain guidelines where I have already made mine since I've been into practice, and depending on what I get a squint, say is supposed to just give you, if I get a 35 prism diopter of exotropia, I do 7.5 millimeters of LR recession. But for the exam, for the students to say, you can say that for any recession, effect is more compared to resection when you operate. If you're doing a recession of MR, gives more effect than recession of LR. Hence, if you do 1 millimeters of MR recession, you'll get 3 diopters of effect. If you do a 1 millimeters of LR recession, you get about 2 to 2.5 millimeters of effect. So that's what you can tell for your exam. And remember, recession effect is more than resection. That's why if you need to operate on anything, a recession surgery is better than a resection. Second is, if you have to operate both resect, you will do first recession, then you will do resection. You will not say other way around. Okay.
That is very important point. Yes.
Yes.
Very well said, ma'am. Thank you so much. Yeah, my questions are over. Thank you.
Thank you, sir. Any questions from you, Gayatri, Priyanka? You want to take this opportunity to ask anything? Okay. Dharade sir, any tips for PGs for performing in the exam, especially when they have been asked the questions which they are even unaware of? Any tips for the PGs?
So actually, I'm very happy to share that Dr. Priyanka is the first PG of GMC Kolhapur. And we are training her as just like from the basics, how to give, how to examine the patient, how to diagnose provisionally and final diagnosis, and to manage. So each and every tip is very important for all the students. There should be what Dr. Santosh sir already told: read, read, and read. Read, read, and read. That is the only tip for the residents, all the residents. Thank you, Sunil.
I would add discuss it with your co-JRs So that
Yeah.
also helps in speaking out at the Viva confidently. So always, whenever there is case, go for discussions.
Definitely, the examination of pediatric patients, especially squint cases, are very, I think, challenging. So I think we should learn, and in hands-on also we can keep that.
Yes, hands-on.
Yeah,
Yes, yes.
that's very important.
Actually,
There are more
people
and
are
more
always
case
very scared
presentations.
of squint cases. So I would like to assure them the squint is just like maths. So if you
Yes.
understand few basic principles, you will answer. And if you answer and satisfy the examiner, nothing like it, you will get full mark. So don't be scared of squint cases. They'll give you lots of good marks also and answer confidently. Don't be scared of squint.
So present more and more cases when you get squint with your
Yes.
mentors and seniors, so you'll be able to answer better and you will cover. Don't start squinting yourself when you see a patient with squint.
Madam, your opinion about this PG program, what we are running for last 7-8 months?
No, it's excellent, very impressive, and it's very good. That's as Dr. Vaishali said, they are really lucky postgraduates where they're getting, everything on a platter. They are getting people to teach them. They're able to present cases in front of, faculty. So they can get out their fear and they can learn as well. So it is really amazing and it's definitely going to benefit them. So I think I congratulate MOS for doing this kind of work for the PGs. Really good.
Thank you very much.
So
Sir, I
thank
want
you.
to add one. Yes, I'm very thankful to MOS PG program. Actually, what is happening in most of the medical colleges, there is faculty deficiency, and in most of the medical colleges, ophthalmology departments are collapsing, and there are no PG activities conducted in the periphery. So this is one of the best program which is conducted by MOS, and Dr. Sumit is taking so much hard work. Dr. Agrawal sir, Atul sir, Aditi ma'am, or everybody of MOS taking very hard work, and this is very good platform for all the students, not for the students, but it is good for the teachers also. Thank you so much.
So thank you, our mentors, panelists, PGs, and our moderator. And thank you all of us for being with us. And thank you, Santosh sir, and the MOS platform. And we will continue with the next specialty next month and see you on the first Thursday again. Thank you,
Yes.
and call it a night.
I request PGs and teachers also to give your valuable feedback, suggestions, whatever you have. And also you can communicate to MOS scientific committee for your any queries. Please come
Yes.
forward and also attend these webinars and hands-on in large numbers.
Yes.
Yeah. Thank you. And
Thank
good
you
night.
for
everyone.
having us. It was wonderful participating. Thank you.
Yeah.
Yes,
Thank you, Vaishali.
Thank you, sir.
Yes, thank you.
Thank you.